Hey everybody, this is Scott Williams from the EMS Education Department. I'm going to talk to you about ventilators today. This first section of a three-part series is going to talk about terminology, some theories of respiration and mechanical ventilation. The goal of this is to go through some terminology so that we can all talk the same language and understand the rest of this course to where we get to talking about strategies and different vent settings based on patient conditions. The course is going to review the physics of respiration, the terms that we use, and the ventilator equipment. Part 2, we're going to set up the modes of operation, come up with some strategies to apply to different patient conditions and situations, as well as talk about non-invasive. We're going to modify settings based on patient dynamics, and at the end we'll do some case studies so that we can apply some of this new knowledge. Part 3, we're going to talk about troubleshooting, what to do when everything doesn't go quite right. We get some alarms, we get some lights coming on, things making noise. What do we do? So we're going to go through all this stuff together. Here we go. Start off with, you're probably feeling a little bit like this guy on the left. Not happy. Guy on the right, the new ventilator, lots of stuff, scary, who knows what's going on. The course objectives, we can probably fix some of this stuff. We're going to talk about some ventilator terms. Talk about some concepts of mechanical ventilation and some theory. We're going to talk about choosing a mode and a strategy based on the patient that you have in front of you. We know that all these patients that we deal with, each one's a little bit different, but we're going to divide them into two categories for the most part and make this a little bit easier to deal with. Give you some settings to go with, at least start out with your plan, so that way you can tweak the settings a little bit based on the individual patient. Last thing we're going to do after we do our case studies, do some troubleshooting, see what we can do to get those alarms to stop going off and what to do in case things don't go quite right. Hopefully when we're done, you feel a little bit more like this guy on the left and the vent looks a little bit more on the guy on the right and things are good. Alright, so what's so great about using ventilator versus BVM? We've used the BVM for a long time. If you've been in the business at all, you've used it a lot. Okay? It works really good. You don't need any power. You operate it yourself. You can feel the compliance. You control the rate and the depth of respirations, and it's really effective. What's wrong with it? Well, it can be inconsistent if you're inconsistent, or whoever's using it is, and it can fill up the stomach full of air. This can obviously cause problems with emesis and getting stuff in our airway that we don't want. It requires your full attention because you control the rate and the depth, so if you change, then it's changing the ventilations for your patient. You got to pay attention. After you do this for a while, if you've done this for 20 or 30 minutes, it's going to wear you out. Okay, it does waste O2 because we're blowing in tons of O2, 15 liters a minute or whatever, and it's going to use a lot of blow-by, and it does waste oxygen. And if you're not careful, it's hard to keep that seal on the mask. If you're just doing a bag valve mask and not using a tube, it's really hard to keep that seal and get effective ventilations if you're not careful. So, the ventilator, there's a good picture of it. Kind of shows you what you're dealing with. Got a lot of buttons on it, a lot of knobs. What's so great about it? Well, what's so great about it, it's got a lot of variable settings to help make your patient comfortable and make sure that they're ventilated properly. You can give a consistent rate, volume, and pressure, and you can control your FiO2 a lot better than we could on the old vents. Your patient will be more comfortable. You apply certain modes and settings. You can give adequate ventilation and oxygenation and make your patient more stable. It's going to alarm and tell you whenever something's going wrong, give you a chance to fix it. What's great about this vent is it gives you a window whenever you have an alarm, and if you read through the stuff on the screen, it'll tell you all the possible causes of that type of alarm, and at the bottom it'll give you a recommendation of what you should do. It may just say ventilate the patient manually. At that point, you just put them back on the BVM until you figure out what's going on. It doesn't take any effort for us. Once we get it set up, we can do some other things to take care of our patient. The bad things about it requires lots of training and practice, continuing education. When you're in paramedic school, you probably learn lots about vents, and I don't know, maybe not. But today we're going to talk about this stuff and hopefully clear it up a lot. There is a decreased ability to feel compliance because now that this thing's ventilating, you don't feel it. If you know what to watch for, those peak pressure settings, some of the other stuff, it'll tell you how your patient's doing on this vent. And you can kind of get a sense of the compliance. And should it change, it should alarm and tell you. Some stuff you need to know: oxygenation and ventilation. Those two are different. Minute volume, we're going to talk about this a little bit and what requirements we have for our patients. IE ratios, which can be really important when we talk about our different strategies. We're going to talk about ventilation pressures, PIP, PEEP, MAP, all these new terms. First thing is oxygenation. Of course, we know that's our ability to get oxygen to the cells of our patient so that they can do cellular metabolism and all that complicated stuff, and they stay stable. We know that shock is kind of the opposite of that. So we want to make sure we get good oxygenation. It's not simply a result of ventilation, it's really diffusion. Ventilation is moving air in and out. Some of the things that block us from doing good oxygenation are pulmonary edema, bronchoconstriction from asthma and COPD, pneumonia, ARDS, and there's a whole lot of other ones. Here's some small list of things that could cause oxygenation problems that we can probably do something about. Get a carbon monoxide environment, you remove them from the environment, you give them lots of O's, your patient will get better. Sometimes it takes a long time, but remember that carbon monoxide gives us those false SpO2 readings that may look like our patient's doing good when they're really not. Fluid and mucus obviously block that diffusion from occurring, so oxygenation is not going to occur if the fluid and mucus is in the way. Hypovolemia and shock, that's a perfusion problem. If we can't get good perfusion, then we can't get good oxygenation. Water vapor, high altitudes, and decreased oxygen atmospheres can also cause us some oxygenation problems. So we have to increase our FiO2 and kind of combat those things. Now ventilation, like the room you're in right now, it's being ventilated. It's not necessarily being oxygenated. Ventilation is just moving air in and out. It has to do with volumes and pressures. Okay, we're going to control those volumes and pressures with our ventilator and have targets that we're going to shoot for and volumes that we're going to apply to patients based on their weight off of a chart and ideal body weight. If you consider minute volume, the amount of air that we breathe over a minute, that comes for most people to about 60 mils per kg per minute. It's increased greatly whenever you have a ventilated patient. It's doubled to 120 mils per kg per minute. Why would that be? Well, whenever we ventilate a patient with a ventilator, we've got a lot of dead space. The tubing, the ET tube, all that is extra space, and all that has to have air move through it to get to the patient. So if you look at minute volumes in the patient that's not intubated versus the one that is, and you look at these numbers, a guy that breathes 500 mils every breath and he weighs about 70 kilos, well, his 60 mLs per kg per minute comes about 4,200. He's only got to breathe 8 times a minute to get that. If you intubate that guy, you've got to increase that rate a lot because you can't breathe more volume for him. He's got a certain given volume in his lungs that can be exceeded, so you've got to increase the rate to compensate for that increase in dead space. We're going to use the term centimeters, or I may say sonometers of water instead of millimeters of mercury. We're really comfortable with millimeters of mercury. We're using blood pressures, but we're using such low pressures in the airway comparably to the blood pressures. It takes a lot to move mercury. Mercury's really heavy. I put a comparison on here between a can of soda. If you had it full of water versus full of mercury, you're talking about less than a pound, and if you put mercury in that same can, it's going to weigh over 10 pounds. That's a dramatic difference. Since we're talking about ventilation pressures, these are fairly low pressures. We just use centimeters of water, and that gives us a nice range so that we can measure these lower pressures a lot more effectively. All right, now, ventilator terminology, we're going to use words like PIP, or peak inspiratory pressure, is probably what I'll say, and we're going to target about 30 centimeters of water. Right between 25 and 35, we're probably going to have our target set at about 30, max of about 35. There may be conditions where we go a little bit higher than that, like your COPD patients that may take a little bit more pressure to get a certain volume, but still, remember we're talking about pressures and volumes. We've got to kind of compare both. You can't change the volume very much, and you got to be careful with those pressures. This peak inspiratory pressure is the pressure that meets, essentially it meets the bronchioles. It's not necessarily the pressure that meets the alveoli, and I'll talk about that in a second. We consider PEEP. This is positive end expiratory pressure. I'm sure you've heard of PEEP, and we all know that PEEP is that end expiratory pressure that's left in the alveoli after the patient has had a breath given, and this is when they're expiring. This is the pressure that keeps those alveoli opened up so that they don't collapse and get atelectasis. It's really hard to open those alveoli up with every breath, and a little bit of PEEP sometimes is a good thing. Our physiologic PEEP is about 3.5 or 3 to 5. So we've got to keep a little bit of that there. As you can imagine, like if you blow up a balloon, it's really hard at the beginning, but once you get that initial breath in there, then it's a lot easier to blow it up. Alveoli are much like that whenever you're ventilating them. Now, pressure support, this is something that a lot of people don't really understand very well, but it's not that hard to get. Pressure support is in those modes where we're doing bilevel or BiPAP type ventilations, or we're doing at SIMB, which is a synchronized mode of breathing with a patient that does have a respiratory effort. And we give them a little bit more pressure so that they can get a good volume in every time they take a breath. Just a supportive mode. So when you think about pressure support, remember that the pressure support is added on top of the PEEP. So if your PEEP is, say, 5 or so, and then you give them a pressure support of 15, then ultimately they're getting about 20 with every breath. They're getting that 20 on every breath and then getting 5 of PEEP. So just make sure you add the pressure support on top of your PEEP so that you keep those pressures from getting too high. Now, plateau pressure, very important setting. Right now our vents haven't been programmed for this, but they will be soon. This pressure right here will help you to understand what kind of pressure your alveoli are receiving. Because a peak inspiratory pressure happens so rapidly, it may not really indicate to us what the alveoli has received. It may just be the resistance created by the air hitting in the bronchioles and getting resistance. If we do an inspiratory hold while the patient's getting a breath and hold that long enough, we get a plateau pressure that's very similar to mean airway pressure, and it tells us what pressure those alveoli are feeling, and we're shooting for about 30. All right, we got a couple of modes with peak inspiratory pressure. You got a volume mode and a pressure mode. Now we're going to use volume mode for the most part, but we need to understand both. A volume mode is where you set a tidal volume based on ideal body weight. You can use a chart or you can calculate it. You can just maybe look at a person and see about how tall they are. You know, if they're 5'2" and they weigh 250 pounds, we know that we're not going to ventilate that person at like 6, or 800 mils because they don't have those size lungs just because they're overweight. Use ideal body weight based off of height, use a chart or whatever to calculate that, and we're going to do some calculations to get some tidal volumes to give us a good start. Whenever you use a pressure mode, what you're doing is you're going to initially set a inspiratory pressure or a peak inspiratory pressure target. Whenever you do that, your tidal volume is going to be outlined, and it's going to be a result of meeting that pressure. If there's a lot of resistance in the lungs and you set that pressure at, say, 30, you got to watch that tidal volume and make sure it's delivering an adequate amount of tidal volume. If it's only delivering like 250 or 300 cc's, then you've got to maybe increase that pressure a little bit to give them an adequate volume. We're probably going to use volume mode most of the time, but you probably should understand what the difference is between volume mode and pressure mode. All right, I talked about PEEP a little bit. Remember that physiologic PEEP is 3 to 5. That's what we're all doing probably right about now, right in that range. We're not allowing our alveoli to completely get deflated because it's a lot easier and less respiratory effort for us to keep them just open so that they're ready for that next breath. Okay. Whenever we think of PEEP, you should think of FiO2. These two should work together. Keep a level of FiO2, whether it's 40 or 60%. If you're having trouble oxygenating your patient after you've already tried 100%, you tried titrating them down, you might need a little PEEP. It works great with conditions that result in fluid in the alveolar space, such as pulmonary edema, ARDS patients, pneumonias, and near drownings. All right, I talked about pressure support. This is used in BiPAP mode, also in SIMV, which is a synchronized mode. It breathes with the patient. Now, BiPAP mode we'll probably be using in the future. Need to just understand, it's like a CPAP, but it also gives an inspiratory pressure. We may set an expiratory pressure with about 5 centimeters of water in the PEEP, and then set that pressure support to about 10 or 15. That's the pressure they get with inspiration. The PEEP is what they get on expiration. Okay, any pressure support setting is added to the peak pressure. That gives you your overall pressure. If you want to see the pressure support, there is kind of a theme with the vent. If you want to see something related to a pressure, go next to the peak inspiratory pressure on the screen right there, and there's a button just out to the side. Hold that down for 3 seconds. The pressure support option will pop up here. Now, whenever you set it up in CPAP mode, you're going to want to turn this to 0, and all you got to do is hold that button down next to the PIP, the PIP pressure, and hold it down. Turn that to 0 with the little dial right below the screen, and then hit OK. Every time you change a setting on this vent, you change it with the dial, you hit OK. When you change that setting, while it's happening, the vent is not changing until you hit that button and say, that's what I want. So, for CPAP mode, that's what we're going to do. We're going to set PEEP at 10 and turn off the pressure support. Until we do bi-level, we're not going to worry about setting the pressure support at anything. We're going to always have it at 0. All right, I talked a little about plateau pressures. These are really important to understand because they're coming in the future. These vents will be programmed to give you a plateau pressure. Our target is 30. This is how we get lung protection. We don't want to overinflate. We don't want to create pneumothorax. We want to make sure that we've just ventilate to a certain pressure that the alveoli are getting, and that target is 30. And that's just an inspiratory hold. As soon as the patient gets a breath, hold the inspiratory hold button, get that plateau pressure. You adjust this with tidal volume. You don't adjust it with anything else. You got to change the tidal volume. If you don't have enough plateau pressure, you just increase the tidal volume in small increments until you reach that pressure. All right, inspiratory flow rate. You get to this by pushing the button right next to breaths per minute. If it has to do with breathing, it's going to be off the side right here. Hold this button down for 3 seconds. As you see, you got some control parameters. This rise time. Rise time is how fast the patient gets a breath. Some patients may need a little bit longer to get that inspiration in, but that's going to be pretty rare. Most of your patients are going to need a rise time of about 3, and I believe that's where the default is going to be. You probably won't have to change this, but if you run on a patient that needs a little bit more time to expire, such as an ARDS patient, maybe somebody with a little bit of pulmonary resistance, it's not a comfortable way to breathe, but it may be effective in getting that patient oxygenated well. So that's how you change that setting. Most patients like a rather short rise time or an inspiratory time. All right, FiO2, as an actual definition, this is a fraction of inspired oxygen. This should be 100% for hypoxic patients that are being resuscitated. After resuscitation, you can lower this down to about 40 to 60, based on whatever your patient needs. Well, I say that because we're shooting for a target of SpO2 of 95 to 99. I don't want them at 100, not very long, because I want to know where they're at as far as their partial pressure of oxygen in the blood. And if you put a patient at 100% SpO2, you have no idea how far past that they could have partial pressures of 300, 400, or 500 if you've hyperoxygenated them. And we know that that's not really helpful for our patients due to the free radical theory, which I'm not going to go into right now. But I want you to keep in mind, you want to shoot for 95 to 99. That's the optimal range for SpO2 on our patients. If you reach 100%, you can gate this back down. If you gate it down to 40 and the patient starts desatting, you can bump it up to 50 and 60 and find out where it is that they need to be so you can hit that target. All right, so we're talking about modes of mechanical ventilation. We're going to use assist control, which means that the patient gets assisted with every breath that they try to take. And if they don't try to take a breath, then they're going to get whatever you set the ventilator at. They're going to get that volume, they're going to get that rate. You'll see the resulting peak inspiratory pressure. I want to point out to you that this volume right here is solid. That is what you set. Every solid number on here is a setting that you can control. If you see an outline setting, that is a resulting pressure or a setting that the vent's giving you after every respiration. So every breath the patient takes, they're going to get the volume and the rate that you set for them. You'll see what the peak pressures are based on what the vent sensed after that breath. You got to consider a patient that is breathing, they may be hyperventilating, And if they're hyperventilating, they may need a little bit of sedation and some pain control so that they're more compliant with the vent and a lot more comfortable. Another thing you can do is adjust the trigger. I'll talk about triggers in just a minute. You got a volume mode of mechanical ventilation, you got a pressure mode, and I've already referred to those, so I'll go into that a little bit more detail. Here you're going to set a peak inspiratory pressure. You can see that setting right here, and notice that it's solid now, and now your tidal volume is outlined. So you set this peak pressure, you could set it at whatever, 20, 25, probably between 25 and 35. Your max is going to be about 35, and it's going to give you a resulting tidal volume. You want to make sure this volume is close to what their tidal volume should be, but taking into account anything that might diminish that tidal volume, such as a big pneumonia or some fluid in there. In that case, we may need to use a little bit of PEEP. All right. So, our next setting, inspiratory-expiratory ratio, commonly known as the IE ratio. Common misnomer on this is not a measure of seconds. Okay, this is a ratio. Most breaths are given in about half a second. If you have an IE ratio of 1 to 2, you give a breath in half a second, then that patient's going to expire for a full second, or twice that. Okay, so however you set this, based on the rate, is going to be a ratio, inspiratory to expiratory time, but not in seconds. It's just going to measure one against the other. Now, this is going to become an important setting when we talk about obstructed strategies, because we're going to want to increase this IE time to about 1 to 4 or 1 to 5, because our goal is to make sure that with an obstructed patient, we give them time to expire. All right. Now, if you hold down that breaths per minute button over here, right out to the side here, you get a window that pops up. Remember, your rise time tells you how quickly that patient's getting a breath. And those lower settings, the lower numbers, are whenever the patient's getting a quicker breath. Higher settings when they're getting a little slower breath. The control parameter up here, i.e., you can change to I time. Not something you're probably going to use, but you can understand if you've got a patient that you pick up from an ICU and the ventilator is already set to an inspiratory time, this is a matter of seconds that it takes to give that breath. And you might have a RT that's telling you, okay, I'm giving the breath over, 1 second. Well, you can also do that with this vent. Probably not a common thing you're going to do, but if you hit that breath per minute button over there, you can change the way that breath is given. Now, your main menu button, as you see on the left side of the screen over here, it's going to give you all these options to modify. Most important on this list, besides your alarm and your power-up settings and your pulse ox, which this vent's not equipped with, your trigger level and your O2 reservoir, those two things are something that you're going to have to modify from time to time. Your trigger level is going to be how much pressure does the patient have to take in a breath to cause it to go ahead and give a breath. I'll talk about that here in a second. There's also an O2 reservoir, which means over on the right side of this vent, as you can see right over here, this little black thing, that's where the air intake is for atmospheric air. Should we have any problem with the high pressure line coming in here, we can always take that off, put a BVM on this side right over here, and plug it in, hook it to oxygen source, and provide about 10 to 12 liters per minute, and provide oxygen that way. Now, whenever you do that, you do not have to change the FiO2 setting. Just leave it at 21%. Set your BVM. It fits perfectly in that little hole, and you've got a reservoir now that the vent will take that oxygen from, and you do the ventilations with that reservoir. So that reservoir setting is set to off on default. If you go to this setting, you've got to hit the menu, go to O2 reservoir, modify that setting by turning the knob, and then hit the OK button. Let's talk about triggering for a second. Every time we take a breath, that creates a negative pressure. It doesn't take much for this vent to sense that pressure. If the patient starts to breathe on their own, all they got to do is generate a -2 centimeters of water, and the vent will go ahead and supply breath. If the patient is hyperventilating or over-breathing the vent, we can change that trigger to make it to where they have to pull a little harder and where they can't trigger the vent, but they only get the respirations that the vent wants to give them. That'll keep your CO2s from dropping. I suggest, though, offering your patient some sedation and pain control if you get into a situation where they're over-breathing the vent or bucking the vent. You want them to comply, you want them to be comfortable, and hyperventilating and bucking the vent are signs that your patient's in distress. Now, I mentioned the O2 reservoir. There's what that screen looks like. You're going to see right here it's defaulted to off. You're going to want to highlight that and then turn the knob to this where this says on and hit OK. That way you can hook the BVM to the side and supply that lower flow oxygen through the reservoir through the BVM. This is a great way to conserve a little bit of oxygen if you need to. If you're going a long distance from the truck to an ICU that may be far away or whatever, you may have to get down to this. So now you need to know how to set that up. Alright, so hopefully this has helped a little bit. Hopefully you feel a little bit more like the guy on the left and the vent looks a little bit more on the guy on the right. Get ready for part 2. Should be good. We'll talk about some strategies and hopefully help you get an idea of how you're going to set up the vent for whatever kind of patient you're dealing with.